Hi, everyone. Thanks so much for joining us today. My name is Haley Cronquist. I'm the policy attorney here at Long-Term Care Community Coalition. For those of you who are new, LTCCC is a nonprofit, nonpartisan organization dedicated to improving the care and quality of life for people living in long-term care. We do our work through policy research and analysis, systems advocacy, public education, and we are also the home to 2 local ombudsman programs. So today's webinar, we thought we would go back to basics. We have our executive director, Richard Mollett. He is going to talk you through the foundations of nursing home resident rights and offer tips to support your resident-centered advocacy. And those of you who don't know Richard, you'll see his face a lot if you attend our programs. So he's been doing this for a long time, and we're pleased to have him today. So Richard, I will hand it over to you.
Thanks, Haley. A quick question for you. The materials for today's webinar, I said that in my email this morning that they'd be available next Monday because of the holiday. Does that sound right? Just so we let people know.
Yes, that's probably closer to true. But there are the slides are up today, and you can also access our fact sheets on today's webinar page. But the video will likely be closer to next week. Yeah. Thanks.
Perfect. Thanks so much. So I've been thinking about this program a lot, and thank you everyone for coming today. Nice to be here. Nice to be presenting. I've been thinking about this program a lot because, I speak to residents and families and ombudsmen and even surveyors at times, and certainly attorneys and other people who work with residents and families. And I see, over and over again that there are large gaps in understanding of what nursing homes are supposed to provide, what residents' rights are, et cetera. And there's nothing wrong with that. There's no reason why residents and families should have to be experts about the nursing home rules and standards. However, given the challenges to accessing decent care and quality of life and dignity in our nursing homes, it's been our work over, I'd say, especially the last 10 years, a large portion of our work has been to educate residents and families and ombudsmen and others who work with residents and families and help them understand what their rights are, what the rules are, and what expectations they are entitled to. I know it can be really frustrating. I've been a family member a number of times myself. I'm a nursing home resident over the years. I know it can be extremely frustrating and challenging to try to get good care, to try to get attention paid to the issues that my loved one has had in a nursing home. But I do believe that having access to knowledge, having access to the residents' rights, and some knowledge of how to advocate for that resident is helpful. And that without that knowledge, that it's certain that a resident is not going to get the care or services that he or she wants but is not getting. But with that knowledge and equipped with the appropriate tools, there is a much better chance of accessing good care and life with dignity. So there's a lot of things that I really would have loved to talk about today. I have a very large slide deck. As always, if you've been to any of my programs before, I do provide a lot of information, but everything is available for free, downloadable, and accessible on our website. As Haley said, nursingHome411.org. So there's no reason to take notes. There's certainly no reason to memorize everything. What I really want to do is to provide some highlights, some baselines for nursing home care over the next 45 or to 50 minutes or so. And kind of plug in with you all as to what residents have the right to receive and to expect. So I'm going to start with some background, and I often do this. I've gone into a little more depth in today's program. Number one, I thought it was important to just dispel a myth or a common misunderstanding that nursing homes and assisted living are very similar. Nursing homes and assisted living do provide services to people in very similar situations, and increasingly so, people who have dementia, people who have other cognitive impairment, people who need help with the activities of daily living, help with feeding, help with medication management, et cetera, they can go to a nursing home or they can go to an assisted living. However, there are significant differences between nursing homes and assisted living, and that's really important. So just very briefly, I mean, nursing homes in the United States are regulated by both the federal government and by the state government. And as a result, there are many strong federal rules around nursing home care, around who can provide care. It has to be an RN, an LPN, or a CNA certified nurse aide. Who qualifies for nursing home placement, whether you belong in a nursing home or not. There are pretty specific guidelines around that, how care is paid for, what residents' rights are, et cetera. And there are also strong mechanisms for enforcement, some of which we'll talk about today, for ensuring that residents' rights are implemented. As I mentioned at the start, in terms of the challenges, quite often those rules are not very well implemented, and too much nursing home care is substandard, and there's too much abuse and neglect, but at least those rules and those mechanisms exist. With assisted living, there are no federal rules regarding safety, quality of care, who provides care, et cetera. There are only state rules. State rules vary and they tend to be rather weak. In addition, the enforcement for nursing home is often even weaker than it is, for assisted living. The enforcement for assisted living is even weaker than it is for nursing homes. And then lastly, as we'll talk about a little bit today, we have a lot of information about what goes on in nursing home, good or bad. We have very little information about what goes on in assisted living, and that makes advocacy even harder and makes making good choices about assisted living even harder. And we are going to be doing programs on assisted living. Our next program in December actually encompasses both nursing homes and assisted living. We'll talk about that at the very end today. But here we're going to focus on nursing homes. So in a nutshell, as I note here, and many of you have seen that nutshell before, almost every nursing home in the United States participates in Medicare and or Medicaid. Most of them participate in both. And that means they take some money from Medicare and or Medicaid for resident services. In order to do so, facilities agree to meet the standards provided for in the federal nursing home reform law. Now, a state can have additional standards, but a state cannot have less standards, less protections than those provided for under the federal rules. So we pretty much always in our work and all of our materials focus on the federal rules because they are really the bedrock for nursing home care, no matter what state you're in. A little bit about the reform law. It passed in 1987. And the reason why I mention that is because it's not new. Too often we hear from residents and families and ombudsmen that facilities are understaffed at Christmas time or on the weekends, that the medication management isn't good, that there's issues with infection control, as was exposed, of course, during the COVID pandemic, that too many nursing homes tend to have substandard infection control protocols. And the reason why I mentioned this here, 1987, is that the law has been in place for a very long time. And the rules that came out of that law, the rules came out in 1991. So they, in turn, have been around for over 30 years. There's nothing new here. And nursing homes should not be surprised, when they are told about the rules or asked about the rules or are expected to provide care in compliance with those rules. The other thing about the reform law that I really appreciate personally, and I hope that you will too, is that it's very resident focused. Most laws and standards, if you think about them, they apply to an industry, they apply to an industry's output. For instance, if I am Chrysler Motors, I have to have a certain mile per gallon across my fleet. I have certain expectations around carbon emissions, et cetera. It's what I produce. The reform law and all the standards, and we're going to talk about just a few of them today, it focuses on the individual. And when a facility takes in a resident, they are saying that they have the ability and the supplies and the staffing to ensure that that resident can attain and maintain his or her highest practicable physical, emotional, and psychosocial well-being. And that comes again from the law, and it's repeated over and over again throughout the regulatory requirements. As I note here, the law emphasizes individualized patient-centered care. And we're going to talk a little bit about that specifically in a few slides from now. A little bit more about the reform law, though. It lays out specific resident rights regarding good care, regarding residents' rights, regarding both monitoring to ensure high level of quality of care and high quality of life, and life with dignity and choice, and to the greatest extent possible with autonomy. So a couple of examples of what the reform law means is that if I'm in a nursing home and I can go to the toilet, but I need help walking there because I may be unsteady, maybe a fall risk, etc., I should not be placed in a diaper because there are not enough staff to help me get to the bathroom. That is not appropriate care under the requirements of federal law and regulations. Another example is if I have dementia and I'm exhibiting so-called behavioral symptoms of dementia, maybe I'm crying or lashing out or making noises that sound odd to somebody else, I should not be medicated to make my care easier for staff. There are standards of care, both specifically for nursing homes, as well as professional standards of care that nursing homes are required to provide for dementia care, which call for non-pharmacological approaches to the so-called behavioral symptoms of dementia. We won't get into that much here. I'll talk a little bit later on about our dementia care advocacy toolkit, but we do have a lot of resources, again, on our website. Everything is free to use and to share with others. So I'm going to talk about a few nursing home standards, starting with nursing home staffing. Why are staffing standards so important to us? One, staffing is widely considered to be the most important corollary when it comes to safety and dignity in nursing home care. Nevertheless, far too many nursing homes persistently fail to have sufficient staff. We track the staffing data and we publish the staffing data for every nursing home in the country that's in compliance with the federal reporting rules about staffing. We publish those data every quarter when they come out from the federal government in usable, downloadable, searchable files. And those data indicate that every single quarter, and has been very consistent, about 75% of nursing homes fail to have enough nursing staff to even meet the basic clinical needs of their residents. So that's why we're all here. That's why you're all here today. That's why I do what I do. That's why the ombudsman do what ombudsman do, because we need to be vigilant and do what we can to ensure that residents are safe and receiving appropriate care. I just want to mention a couple of the other bullets here. Too many nursing homes use staff that don't have the necessary competencies to meet the needs of residents. So it's really two things. One, sufficient numbers of staff, and secondly, that those staff have the competencies to meet residents' needs. Too many nursing homes, this is really, it was hard for me to write and think about, but too many nursing homes expect residents and families to accept inadequate staffing. And I think that's become very prevalent and very dangerous in our society. And it's not anything new, although it's certainly been exacerbated by the staffing shortages that have increased as a result of the COVID pandemic, is that nursing homes say, well, we just don't have enough staff to do that. And we're supposed to accept that. When a nursing home doesn't have enough staff, they are not supposed to be taking in additional residents. That is a fundamental requirement. It is not a warehouse. It is a resident's home. And again, they're making the fundamental promises under federal requirements for which they're paid and which they voluntarily agree to have enough staff and enough supplies and services to meet residents' needs in a dignified way. Lastly, this is dangerous not only for residents, but also for staff. Being a CNA is and has been for many, many, many years, one of the most dangerous professions in the country. So I'm going to talk about some of the specific rules regarding sufficient staffing. Those of you who have seen our materials before will be familiar with this, but the 42 CFR number, that's the the citation to the Code of Federal Regulations. This comes from 42 CFR 483.35. And the reason why I include that here, and in all our materials, you'll see that in our fact sheets, in our primer, and other guides, et cetera, for nursing home care, is that it gives you a solid base for the citation. For anything that we're talking about in terms of resident rights. It's not something that I am making up as a resident advocate because I'd like things to be this way. This is what the federal rules are requiring. And if you're ever talking about this within your facility to care staff, to administration, et cetera, who are trying to say to you, oh no, we just don't have enough staff to do X, Y, or Z, you can say, no, this is actually comes from the federal rules. Secondly, you'll see this throughout our materials as well, we include the what's called the FTAG here, F725. And that is important for residents and families and those working with them, because that FTAG is what surveyors, nursing home inspectors use when they cite a facility for a deficiency in a certain standard. So if a facility was found to have insufficient staff, they would be cited for F725. And every nursing home is required to post in a prominent place and make available in its facility the latest statement of deficiencies. And those statements of deficiencies will include the FTAG that was cited. So if you're a resident, a family member, a resident or family counsel, an ombudsman, an attorney, or someone advising residents, and you see that they've been cited for F725, you can come back to our materials. You can go directly to the Code of Federal Regulations, and you could see what it was that they were expected to be doing and how it was they failed, so that you can have a better understanding of what changes they are supposed to be implementing to correct that problem. I hope that makes sense. But again, it's not something that you have to memorize. These are just foundational resources that we include with all our materials to make them easier to use and to make them also more useful for you in your advocacy. So sufficient staff. The facility must provide services by sufficient numbers of each of the following types of personnel on a 24-hour basis to provide nursing care to all residents in accordance with their care plans. This includes licensed nurses and other nursing personnel, including nurse aides. Nurse aides provide about 90% of bedside care, and then LPNs and RNs, licensed practical nurses or licensed vocational nurses and registered nurses, provide the other care, and for RNs, for RNs in particular, for the oversight of that care. Having sufficient staff, having sufficient CNAs in particular is very important to make sure residents are getting the services, that they are being regularly monitored and cared for. However, study after study has shown that having sufficient RN staff is critically important, because RNs are really the only one in the building on a regular basis who can provide oversight and professional monitoring and assessment of residents. So that makes them particularly important. I'm going to spend a little more time here. So nursing services, again, these are the federal requirements. Every nursing home must have sufficient staffing with the appropriate competencies and skills, as I mentioned again, enough staff and appropriately trained staff to ensure resident safety and attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident, as determined by resident assessments and individual plans of care, and considering the number, acuity, and diagnoses of the facility's resident population. So this to me was just so important. This is all language from the federal rules and guidance. And what this means is, again, enough staff, but the staff have to be appropriately trained. You just can't throw people onto the floor without having appropriate training. And what is that all required to do? Must. Again, every nursing home must have, not may, not can, not should, if it has enough people in the area that it wants to pay $8 an hour or $15 an hour to, not if it meets with their profit margin or not. Every nursing home must have enough staff with the appropriate competencies. For what? To ensure that residents are safe, but also that they're able to maintain and attain their highest practical physical, mental, and psychosocial well-being. All those things are important. All those things are specifically enumerated in the federal rules. How is that identified by the facility? What are the expectations? By a meaningful resident assessment, and resulting from that assessment, an individualized plan of care that responds to the needs and the desires and the goals that were determined in that assessment. And then lastly, this last bullet is that they also have to do this, the facilities have to do this in consideration of who's in the facility. This is not operating, again, it is not operating like, oh, we're going to have 2 RNs, we're going to have 1 LPN and 6 CNAs for 250 people in our facility. And that's just what we were able to hire, so that's how things are. No, they specifically are required to consider who else is in the facility, what their needs are, what their diagnoses are, and plan in a responsible way for their staffing. Some federal guidelines for the registered nurses. The facility is required to designate a registered nurse to serve as a director of nursing on a full-time basis. The role and the responsibilities for each individual serving as a director of nursing must be clearly defined, and all facility staff must understand how these responsibilities are shared among the individuals functioning at the DON. Again, where does the buck stop? The buck stops really with everybody. CMS, the federal government, understands that this is really, frankly, a precious responsibility for people's lives who are very vulnerable and have significant needs. That's why they're in a nursing home. So everyone has to understand this is made extremely clear, as you can see in the federal guidance, that we know what's going on. People can't just throw up their hands and say, oh, I didn't know. I don't know where the DON is. I don't know who he or she is. The roles, the responsibilities it's laid out so that they are clear and the expectations are to be followed. I thought this was an important slide too, so I'm gonna spend a little time on it. Nurse aid competency, because this is an issue I hear about a lot, that the nurse aides aren't familiar with the residents, they're not really sure what to do with the residents or with the residents' needs. They're not clear about protocols, for instance, moving a resident or feeding a resident, etc. So the general rule is that facility must not use any individual working in the facility as a nurse aide for more than 4 months on a full-time basis unless that individual is competent to provide nursing and nursing-related services, that he or she has completed a training and a competency evaluation approved by the state, and that the individual has been deemed or determined competent. For non-permanent employees, this applies too. So facility can't say, oh, we have a lot of contract staff today, blah, blah, blah. No, that is not relevant. A facility must not use on a temporary, per diem, lease, or any basis other than a permanent employee, any individual who does not meet these standards. It is required for everyone who is in contact with the nursing home residents. And I hear, as you can see with all the arrows, CMS, the Centers for Medicare and Medicaid Services, has a statement on competency, quote, a measurable pattern of knowledge, skills, abilities, behaviors, and other characteristics that an individual needs to perform work roles or occupational functions successfully. Really a lot boosting the need to ensure that facilities need to ensure that resident care is appropriate and professional, no matter who the facility is hired to provide it. It's the facility's responsibility to ensure competency, whether it's a full-time, part-time, a staff person, or a contract person, agency person, et cetera. That is not relevant. It should not be our problem. And this language, I think, helps to support that. Just a quick note before we move on. At the beginning of the COVID pandemic, CMS relaxed and waived some of these rules, allowed facilities to use what are called nurse aides in training, or TNAs. That relaxation of the rules has expired. However, finally, it has expired, something we were frankly against in our advocacy. But it has expired. However, the states and individual communities can even apply to essentially continue a waiver of that. And it's something that we are doing a lot of advocacy around, we and other organizations with which we work, to try to get that bolstered up, because frankly, everyone who comes in contact, as this language says, everyone who comes in contact with a nursing home resident should have the training, and the current training requirements are, if anything, insufficient. They need to be increased, not decreased. But in any case, just so you know, for now and in the future, whether your resident is being cared for by a CNA, a TNA, an RN, LPN, including a TNA, CMS has said from the very start that they are not waiving any competency requirements whatsoever. So having TNAs on staff, if a facility is using that, we think it's a poor idea. We think it's dangerous, even more dangerous with residents and staff. However, again, it's irrelevant. The facility has to make sure that every single person has the appropriate training and competencies. How do they do that? Through regular in-service training. The facility must complete a performance review of every nurse aide at least once a year and provide regular in-service education based upon these requirements, which they have a number 2 below. Be sufficient to ensure the continuing competencies of nurse aides at least 12 hours per year, including, they must include dementia management training and resident abuse prevention training. They must address any areas of weakness that's been determined in a nurse aide's performance review and facility assessment. And they also may address the special needs of residents that have been determined by the facility staff. And then for nurse aides providing services to people with cognitive impairments, they also must address the care of the cognitively impaired. Again, getting back to that example that we see far too often of residents being drugged because they have so-called dementia behaviors, et cetera. That is not appropriate. Everyone on the floor has to have that competency, has to be constantly evaluated for that competency, and has to have annual training to ensure that they are competent. I'm not going to get into this here because I want to make sure we move along, but here are some requirements regarding posting of staffing in nursing homes. Since 2003, every single nursing home has been required to post in a clearly visible place the number of nursing staff on duty for each shift. Again, this slide and the other materials will be on our website, but I just wanted to make sure that you all knew that. I've seen that in facilities. And as I mentioned, all these materials, everything I talk about is available, and we have fact sheets, and we have a primer guide to the nursing home standards. And you can see here, this is the fact sheet. Virtually all the fact sheets, except for a few of them, are 2 pages. This is the front and back. So it's easy to print out and to share, to bring with you to a care planning meeting, to bring with you if you're an ombudsman, to a facility and share with residents and families and resident and family councils. But this includes pretty much everything that I was just talking about. A few other standards I want to talk about. One related to just some of the basic resident rights. The resident has a right to a dignified existence, self-determination, and communication with and access to people and services both inside and outside the facility. The facility must, not may, not can, if it should, if there's enough staff, if staff are in a good mood, must treat each resident with respect and dignity and care for each resident in a manner and in an environment that promotes maintenance or enhancement of his or her quality of life, recognizing each resident's individuality. The facility must protect and promote the rights of the resident. And lastly, on this slide at least, the facility must provide equal access to quality of care regardless of diagnosis, severity of condition, or the payment source. Facilities cannot say, oh, that was services that we provide to someone who's on Medicare rehab. Now you're a long stay Medicaid resident, you no longer deserve those services. No, that is not appropriate. Everyone is entitled to equal access to quality care. A few more slides about residents' rights, just to kind of, again, provide some insights into how specific and deep the federal rules and the requirements and the guidance for nursing homes go. So this is from the guidance. The resident has the right to exercise his or her rights as a resident of the facility and as a citizen or resident of the United States of America. Why do I include that there? Because so often, and I felt this even before I started with the Coalition 20 years ago now, is that it seems like you go into a nursing home and you forfeited all your rights as a citizen, and somehow you're now under the the kingship, I don't know how else to put it, of the nursing home operator, and that is just not the case. I want to talk a bit about the intent of the regulations and of the guidance. The intent is, this comes from, again, right from the guidance, the federal language. Each resident has the right to be treated with dignity and respect. This is not my language again, I just want to clarify. All staff activities and interactions with residents must focus on assisting the resident in maintaining and enhancing his or her self-esteem and self-worth, and incorporating residents' preferences and choices. All staff activities and interactions must, and see how this is focused. And I know how different this is from so much of our experience with nursing homes. And I know, when I've talked to families over the years and been a family member, how frustrating it could be to see that the rules are so different from what we often experience in our nursing homes. But this is how we can make change. And this is how we can help the people with whom we work make change, by helping them to understand and giving them the tools to advocate effectively. So again, we have a lot of fact sheets on this, very simple, 1 or 2 pages, as I mentioned, and we have a primer that I'll talk about in a second. Lastly, on this slide, staff must respect each resident's individuality when providing care and services, while honoring and valuing their input. So important, because it so often doesn't happen. Here are some examples, and I'll go these pretty quickly, but these are examples to keep in mind regarding dignity, privacy, and respect. These are not my examples. These examples actually come again from federal language, federal guidance. Residents should be groomed as they wish to be groomed, hair combed, nails cleaned and trimmed, etc. Dressed in an appropriate way for the time and day. Their clothing labeled, if there are labels used for laundry, etc., labeled in a way that respects the resident's dignity. And then when there's a dining and other instances of resident care and activities, we just talked about dining here, the facility and staff should avoid day-to-day use of plastic cutlery and plastic or paper dishes. They should avoid using bibs instead of napkins, unless the resident chooses that, wants to have a napkin as a bib. And these last two, they just always drive me nuts when I see it in a facility. Facility and staff should avoid standing over residents while helping them to eat, and staff interacting or conversing, only with one another when they're helping residents, rather than being with the resident, experiencing with the resident, being present with the resident when they're providing service. And that goes to dining as well as other services too. Too often I see that the staff are talking over residents rather than to residents. And that is really important. All of these things are really, really critical. Sometimes people will say, oh, these issues are not as important as clinical care. And that, in some ways, that's true. Of course, if someone has a bed sore, if someone is malnourished or dehydrated, or has fallen and hurt themselves, or has been abused, those are all extremely time sensitive, to say the least, and dangerous situations. But I've never been in a nursing home over my career where the quality of life was really poor, but the clinical care was really good. So these things are all important demarkers. They're important for people as individuals. They affect both our mental and our clinical well-being, but also they're important to see because, again, at least in my experience, I've never seen a facility where the care was provided in a demeaning way, but it was good. Either the facility is providing good care and is respectful of the residents, or it tends not to be, and that goes to both resident care and treatment, quality of life. So again, we have a fact sheet that just talks about everything I have here, so you can have this material. It's free to use and share. Just go to our website, nursinghomefour11.org. Residents, just very quickly, have serious and significant protections from abuse and neglect. I just didn't want to pass it by without at least, this program by, I should say, with at least mentioning it. So I'll just quickly mention, it's probably hard to see, but in the top left-hand corner, it says that the resident has the right to be free from abuse, from neglect, misappropriation of resident property, and exploitation. Now that's really important. The facility has, it's all really important, but in regard to misappropriation of resident property, the facility has ultimate responsibility for protecting nursing home resident possessions, whether it's a diamond ring or hearing aids. That is the facility's responsibility to make sure that they are not lost, broken, or stolen. And then lastly, I just want to mention, again, this is all, you can download it right now on our website. On the upper right-hand side, we include, this is from CMS, identified facility characteristics that could increase the risk for abuse. They include, but are not limited to, unsympathetic or negative attitudes towards residents, chronic staffing problems, lack of administrative oversight, staff burnout, stressful working conditions, poor or inadequate preparation or training for the caregiving responsibilities, deficiencies of the physical environment, and facility policies that operate in the interests of the institution rather than of the residents. And that, again, is federal language. That's not something that, I agree with it, of course, but it's not something that I made up. This comes from the federal language, from the federal guidance. So a lot of these materials, as I said, we have fact sheets, which are short pieces, but we also have a guide. It's called Nursing Quality Standards of Primer for Residents, Families, Ombudsmen, and Advocates. That's also free to download and use. It's a PDF, and it is pretty user-friendly. As you can see here, we have 49, I think, different residents' rights, and you can use this to look and see what you might be interested in and go from there directly to the topic. So I'm going to talk a bit about the nursing home survey system. Surveys are inspections. That's what they call inspections in the nursing home world. So the question is, if the reform law is so great, we have all these great standards and it's so supportive, it's so resident-centric, why are so many nursing homes bad places to live and get care? And the reason is that even though the laws are strong and the standards are strong, they can only make a difference in the lives of residents if they are enforced. And we've talked about some of our studies over the years, and others have done studies as well. The Government Accountability Office, the Office of Inspector General, study after study has shown that enforcement of these rules tend to be very weak. And that's, again, why it's so important for people to know what their rights are, what their residents' rights are, because with that information, that can help you to overcome some of that, the lack of enforcement. So very quickly here, there are two main agencies that oversee nursing home resident care. One, as I mentioned, the Centers for Medicare and Medicaid Services, the federal agency, and then CMS contracts with the state agencies, normally called the State Department of Health or the Department of Public Health, to perform those oversight functions. That includes monitoring care, doing at least annual inspections on average, and then responding to complaints about resident care. In addition, and we strongly support this, the work of the Medicaid fraud control units. Every state now has a Medicaid fraud control unit. It's a federal state partnership. So the feds pay, I think it's 75% of the cost, and the states put in about 25% of the cost. They generally actually are very cost effective because they bring in money when they find that there has been fraud in care services, including in nursing home care. But importantly, the reason why I wanted to mention it here is that every Medicaid fraud control unit has its own abuse and neglect complaint line. So you can call the INFUCU. If you're not getting a good response from your State Department of Health, you can call the INFUCU and register a complaint there. They don't have oversight authority. They're not the regulators. So they may not be able to help with every single issue, but they are, when they are able to help, they do a really strong job. They have attorney investigators, they are law enforcement, et cetera, and they can also alert the State Department of Health or Department of Public Health. Lastly, but certainly not least, I want to mention the Ombudsman program. Ombudsmen also do not have regulatory authority. They cannot penalize a facility. Excuse me. However, they're the only ones that are going in on a regular basis to monitor care and provide a voice for residents. From our perspective, ombudsmen are absolutely critical, and in terms of ensuring that residents are safe, monitoring facilities, and giving residents and their families a voice in facilities. So I'm going to try to quickly talk about some of the survey process, because I think it's important. This changed about, I think it's about 4 years ago now. In the past, what happened, as I note here on this first slide, is that in the past, a survey team, inspection team would go into a facility, and what we would hear is that they'd close the door, they put a sign up, do not disturb, and they would quite often only speak to the facility staff and the facility administrative staff, and they would do a lot of number crunching behind closed doors, et cetera. With the new survey process that went into effect about 4 years ago now, they're now required to do a lot of that number crunching before they get into the facility to identify who they're going to be interviewing, what kind of issues they want to be looking at past surveys, looking at what is going on with the residents, looking at that data. And that's important, as I note here in blue, because that gives the surveyors time to be looking around the facility and to be talking to residents and families and really assessing what is going on. So these are some of the mandatory tasks for the survey team. They have to look at dining, they have to look at infection control, they have to meet with the resident council, they have to look at the kitchen, they have to ensure, second to last bullet, sufficient and competent nurse staffing. That is a mandatory task now, not something that they could just, aren't expected to pay much attention to. Looking at sufficient staff, because CMS has identified that obviously as a significant issue, as we were talking about before, significant and persistent, pervasive problem. They are required to look at staffing. Here I included, I won't spend time getting into it, but you can download the slide, and we have a lot of information on this, other information on our website, I should say. But these are the components of a resident interview. But interestingly, I just wanted to include the scenario here. One, interviews are expected to take about 20 minutes. So the CMS is telling surveyors, take your time. This shouldn't be just a breeze by a resident's room. It should be sitting down and talking to a resident, finding out what's going on with their quality of life in terms of residents' rights and in terms of course, quality of care. So here, just quickly, for any concern expressed by the resident, you will ask additional questions until you can determine whether the concern can be ruled out or needs to be investigated further, which means you think there may be a deficient practice. For example, the resident said they had an issue with their roommate, but the facility addressed the concern to their satisfaction, you would not need to investigate further. However, you would want to investigate a concern if the resident says they have lost weight recently because of their loose dentures and it hasn't been addressed by the facility. So that's just one example from the CMS itself, the surveyor training. This surveyor training was mandatory for all federal and state surveyors when the new survey protocols came out a few years ago. Here's about interviewing a resident representative and our family member. The expectation, as I note here in orange, at least 3 family interviews. And importantly, as I note in number 2, conducted early enough in the survey to provide time for investigation of any issue that has been raised. And that's really important. This shouldn't be happening when you're walking out the door or the day you're leaving and you're putting together your paperwork. This is supposed to be happening at the beginning so that any issues that are raised by residents and families are identified and addressed. Dining is a huge issue for residents, as I'm sure many of you know. Surveyors are required to observe the first scheduled full meal that takes place in the facility after they arrive. They're expected to cover all dining areas in the facility and room trays when people get food in their room. They're expected to observe enough of the residents' dining experience to adequately identify any concerns, et cetera, et cetera. So it's really making sure that they are looking at dining in a meaningful way. And remember some of the standards we talked about dining. So they should be looking to see, is the resident food palatable? Are residents being talked to or talked above? Are all the residents in a bib? Are there paper plates, or are there actual dinnerware? This is a resident's home and it should look like that. Resident medication issues are a huge issue in nursing homes, so it's required that the state surveyors observe and review medication administration in an effective way. I wanted to focus a little bit on the resident council interview. They are required to conduct a group interview with active members of the resident council. Again, that interview should occur early enough in the survey to afford enough time to investigate any concerns. They have some specific areas that they should be talking about, but in addition, the surveyor should be asking the group about any identified concerns that they might have. And lastly, as I mentioned, this is so important, it is now a mandatory task that surveyors review to ensure that the facility has sufficient and competent nurse staffing. CMS says, and I quote, surveyors are always considering whether staffing issues can be linked to resident complaints or quality of life or quality of care concerns. I'm going to quickly talk about some of the resources and then leave some time for Q&A. So this is our website. This is what the front page looks like. As I said, everything that I talked about and much, much more is available for free. What I really wanted to do in the previous slides was to give just some insights into how robust and how meaningful the rules are. Facilities have a lot of standards. They're being paid a lot of money to care every single day to care for those residents, and they promise to provide good care. How do we get them to meet those promises for their residents? So this is our website. This is our learning center. We have our webinars here, podcasts. We have resources on abuse and neglect. We have resources for families and ombudsmen. We have a dedicated site for our fact sheets, dedicated page for dementia care and antipsychotic drugging, forms I'll talk about a bit for resident advocacy, and we also have guidebooks, et cetera, for assisted living. We have a dementia care and antipsychotic drugging advocacy toolkit. As I mentioned before, too many residents with dementia are not getting the appropriate care and services that they need when they have the so-called behavioral or psychological symptoms of dementia. And we talked about that. We talked about that, I think, at our last program, as Haley mentioned, with Dr. Evans, which is available on our website and YouTube page. He's just an incredible speaker and individual. So if you are working with residents or you have a resident with dementia, I strongly suggest you looking at that. It's really valuable. We put this toolkit together, about 12 years ago now. It was one of the first things we did to kind of work on how can we reach out to families? How can we empower families and ombudsmen and those working with residents and families and ombudsmen? And so we put together this toolkit with thanks to the Fan Fox and Leslie R. Samuels Foundation, which supported this work. I went into 2 nursing homes by our office in New York City, one for-profit, one not-for-profit, every month for 18 months and met with the family council, and they were very generous with their time. And I'm pretty sure at least a couple of those people are still on this program today. People have come to admire and respect and appreciate working with. And they were very generous in helping us to put these materials together. And now these materials are available for free and they're updated as appropriate over the years. This is the page with our fact sheets. As you can see, you can scroll down, you can see some of, or do a search for the different standards that we address, from antipsychotic drugging that I was just mentioning before, to many fact sheets on dementia care, informed consent, resident care planning, resident assessment and care planning, which is really important, the rights of resident and family councils, et cetera. Here is another one of our fact sheets, just to take you back, and you saw a couple of these before. This one is on resident care and well-being. It relates to vision and hearing, skin integrity, freedom from pressure ulcers, resident mobility, et cetera. But we have a host of them. I just wanted to quickly show that, as I mentioned before, every quarter we publish the staffing for every single nursing home, RN, LPN, CNA, the extent to which they use contract staff, the extent to which they have pharmacists and activity staff and social work staff, that we publish that for every single facility in the country, in state, individual state files that are user-friendly. You can download them. You can search for your facility. You can search for facilities in a certain county or a number of counties or in a city, et cetera, and kind of identify what is going on and how your facility is doing. This is how to access them. We have them for every single state in the country. This is our Family and Ombudsman Resource Center. You can sign up, and we welcome family councils to use our Zoom room. This started at the height of COVID, but we're continuing it so people can have a Zoom family council meeting. They can have an in-person, of course, family council meeting without this, or they can have a hybrid, including both the Zoom as well as in-person family council. We have family council resources, including our family council liaison, Janine Ferrari, who joined us a couple of months ago, and she's been doing outreach to family councils and helping to develop family councils. Here are some of our forms and tools for resident-centered advocacy. I'm just going to give a couple of examples here before I close. Here is our resident assessment planning form. As I mentioned a couple of times, the assessment is such an important tool for residents. It's really the foundation of the care plan and the foundation of the services that facilities are required to provide. Too often we hear from families and from residents and from ombudsmen that they're done very quickly. You have 10 or 15 minutes and then the call is over or the meeting's over and people are moving on. So we thought it'd be useful to provide for people a way that they can track some of the issues that they may be having, whether it be a continence issue or a dental problem or skin conditions or concerns about activities, et cetera, so they can track it so that they can have that handy when it does come time for the resident assessment. Here is a preferences worksheet that people can fill out and that they can provide to their facility. It could be done by an individual resident. It could be done by their loved ones, their friends or their family, if say the resident has dementia. And this helps the care staff to understand who that person is, what their preferences are, whether it's a bath or a shower, what kind of music or TV they like, et cetera, things that they enjoy and things that they don't enjoy, so that care can be better provided in a way that is resident-centered and resident-focused. Here is a record-keeping form for resident concerns. Again, it's a way to easily, hopefully easily track some of the concerns that you have. One thing that I heard from families quite often when I was doing those programs, when I was developing the Dementia Care Advocacy Toolkit with those family councils, is that they'd come up to me after I did my little program on a resident right, and they would say, my loved one has had this complaint for months. And I complained to the nurse on duty, and she said it'd be taken care of. It was taken care of for a couple of weeks, but then the problem occurred again. And my response was, that is, of course, completely valid. However, it's very hard to act on. So what we wanted to do was provide people, I should say, with a form that they could say, okay, this is the date when the issue happened, very quickly what the issue was, who they spoke to, what that person said they were going to do, what actually happened. And then if the issue reoccurs, they can put in a new date, new what happened, new staff person, new response, et cetera. And that can be useful so you can track it. So if you have gone to your facility, you've gone to the CNA, and then you went to, say, the nurse at the nursing station, and then you went to the administrator, maybe to the ombudsman, et cetera, that you have paperwork that shows that if you call up the State Department of Health, or if you go to your ombudsman, or if you go to your local legislator and say, look, my loved one is in this nursing home, and we've been having these problems for months, and I could tell you exactly X, Y, and Z, January, March, again in June, et cetera. That puts a lot of credence, it puts a lot of weight into what you are saying. Lastly, we have, of course, our webinars. As I mentioned, they're on our website as well as on our YouTube page. And we have some really neat podcasts. Eric, our Director of Policy and Communications, hosts them. They're really interesting. They're shorter, great to listen to. I listen to them when I'm at the gym, when I get myself to go to the gym, but they're very interesting and helpful. So with that, I am going to close it up and hand it over to Haley. Thank you, everyone who attended today, and happy Thanksgiving.
Thank you so much, Richard. I hope that this webinar was as helpful and informative to everyone who attended as it was to me. I've been doing this work now for a little over 2 years, and it's just really great to go back to the basics and the foundations of residents' rights. So thank you, Richard, for covering so much ground. It was really great. I just want to mention a couple of things before we get to the Q&A. Our next webinar is December 20th at 1 p.m. and it will be on food and nutrition in long-term care. The presenters are Rebecca Priest and Linda McCoy. Linda is a registered dietitian, and you can register for that. I'll have Eric put that link in the chat, so be sure to tune in for that one. And if you can go to the next slide, Richard. Thank you. So Giving Tuesday is a day that just encourages people to give back in any way that they can. And it's a chance for us as a small nonprofit to raise money so that we can continue our fight for improved care and quality of life for long-term care residents. And it's also an opportunity for us to continue to offer you free webinars like the one today and other free resources. So if you are in any position to support our advocacy, please visit nursingHome411.org/donate. And then a few other items at Nursing Home 411. The materials from today's webinar will be on our website at that link. And Eric says that he will get the video up tomorrow. So if you want to watch it again with your family over Thanksgiving, please feel free. I'm sure that would be a really great get together. And you can also find our fact sheets there, as well as, again, the events or the highlights from our event, our 13th annual event, which was a couple weeks ago. And then lastly, on Thursday, December 1st at 2 p.m., our family empowerment team, who Richard mentioned, Janine Ferrari, they will be going live on Facebook to discuss family empowerment and family councils and much more. It'll be a really great conversation, and we hope that you'll join the Facebook Live and you can engage through the comments. So we're really looking forward to that. Be sure to head to our Facebook page and click like so that you can get the update when we go live. Next slide, please. So this is just a thank you slide. Please, if you are not already signed up for our emails, just join our listserv at www.nursingHome411.org/join. You'll get updates for all of our future programs and any other materials we put out. So make sure you're signed up for that. And then long-term care ombudsman, you'll get an email tomorrow confirming your attendance of this program. So thank you again so much for joining us today, and I'm going to get started on the Q&A now. So the first question is from an anonymous attendee. It says, who can a family member go to when the State Department of Health is not addressing these issues?
That's a great question. So I would say two things. One, I mentioned before, the Medicaid Fraud Control Unit. Every state Medicaid Fraud Control Unit, and they're generally in the Attorney General's office, the State Attorney General's office, excuse me. You can go there. They all have a abuse and neglect hotline, as well as, I think, forms. In addition, and I believe we have this on our website, you can, in the abuse and reporting section, you can also contact your local CMS location, which is the regional office of CMS, which oversees the state and is ultimately responsible for ensuring good care and safety.
Great, thank you. The second question, are nursing homes required to provide a motorized wheelchair for residents? I was told by a wheelchair vendor and nursing home that the resident's insurance in the nursing home would not pay for it because the resident lives in a nursing home. It's expected that staff would always be available to push her around, which we know that that's not true because nursing homes are always understaffed.
I don't believe so. I mean, there's nothing specific that requires, to my knowledge, a motorized wheelchair. However, the facility should be making the appropriate arrangements. And this might be something that an ombudsman can help you to navigate with the facility in terms of getting access either to the appropriate equipment and or the appropriate staff help.
Thanks. The next question is from Joan. Who is addressing and speaking to the owners of facilities who are the responsible parties depriving the nursing homes of adequate budgets to meet all of these requirements? Joan goes on to say, my home has issues and I don't want to name them because I know the people there are trying their best. Staff gets blamed, but it's the lack of enforcement against owners that I'm very disgusted by.
Well, I mean, those are essential issues, obviously. I think, Joan, thank you. You really kind of put it all in a nutshell. I would say speaking to your local legislators can be helpful. I know families and family councils, and certainly joining together as a family council can be very, very powerful. If you're able to, please join us on Facebook on Friday, or please visit the web resources I mentioned before. And Janine or Gloria Murray, who's a former ombudsman who is working with Janine on our family council family and family council outreach, could potentially help you. But families joining together has been known to really help residents in a facility, not just the residents with a family member on the family council, but everyone. And this is something that the families can join together. But I would also recommend, speaking to local legislators, letting them know about the issues that you are facing.
Thanks. The next question is from Noel. It says, are Medicaid budgeting rights and P&A personal needs allowance use within the scope of your back to basics regarding nursing home residents' rights? That's not something that we covered on today, but Richard, I don't know if you have any comments on that.
I don't, to be honest. And Medicaid, Medicaid is really Medicaid budgeting and personal needs allowance. Just to be clear, we've always supported an increase in the personal needs allowance, which tends to be extremely, extremely low and does not get raised nearly often enough. But that is, other than that, it's not something, frankly, that is a focus of our work.
Thanks. And it looks like the last question we have here is from Janice. It says, based on one of the regulations you noted, is it a violation for a nursing home to rotate staff to provide an equitable balance of work for staff while disrupting continuity of service for residents? And have you heard of this practice?
So I have heard of this practice. It is not a violation of the nursing home standards. However, I would be asking some of the questions that that I spoke about earlier in this program, such as how is the care in an environment like that? How is care resident centered? How are the staff getting to know the residents and vice versa? And so it's not a practice that we think is a good one. We know, and not just we through personal experience, but there's been a lot of research that has shown over the years that consistent assignment between the care staff person and a resident makes a huge difference in the quality of care, as well as the working condition for the resident, and a huge positive difference, I should say. So there are other ways in which a facility should be managing their staff to ensure that some staff are not overburdened. It's not a good practice, but it's not illegal.
Okay. There is one other question in the Q&A that I just want to mention. It says, any suggestions on how to prevent disruptive residents, those who come into their room and take things or yell at them, from disturbing other residents without over-medicating them?
Well, I would strongly recommend visiting our last program, because actually Dr. Evans spoke specifically about that issue, about resident wandering. But residents can be redirected. There's other things that could be done to help the residents, to help both residents. And this is something actually where Ellie mentioned earlier, the Consumer Voice, which is a national, I'm sure many of you are familiar with the national group in DC. They had their annual conference last week, and there was someone talking about resident on resident altercations, oftentimes resulting from so-called wandering into someone's room, et cetera. And so there are certainly ways in which a resident can be redirected, and which those situations can be addressed as quickly and as comfortably as possible for those residents. And it's not rocket science. It's really just kind of basic, following basic ideas of what you would want to do for someone who may not understand what they are doing to redirect them.
Thanks. So we are about 5 minutes over time now. So I'm sorry for that all, but I just want to read one more comment from Sharon.
Okay.
She's been pretty active in the chat, but this is just a comment from her. She says, We have CNAs who have little to no training. I have not had a shower since January of this year. I still have CNAs who refuse to clean me when changing diapers, so I'm getting stuck. So I'm getting UTIs. It took 5 days to get an antibiotic, and it had a bad reaction a couple months ago, and yet I was put back on it Saturday night. Looks like it was due to a UTI. I had to wait until Sunday night to get a midline put in. This place really doesn't care what happens to us. So I just wanted to wrap up with that comment. It's obviously really heartbreaking, and Sharon, I appreciate you sharing your comment with us. And please feel free to reach out to us, reach out to your local ombudsman for assistance. Richard, did you have any other last comments?
No, but thank you again. Thank you for sharing that. And that's why. Well, we don't have the capacity, frankly, to provide individual advocacy for people, and that's why we do these programs and have the materials on our website. But we do suggest, as Haley said, speaking to your ombudsman, and thank you for so much for sharing your experience, which is, I'm so sorry about, and unfortunately, it's not uncommon, but hopefully, again, with some of the knowledge, et cetera, we can make changes. And as I said, I've experienced this myself, not as a nursing home resident, but having had loved ones over the years in nursing home residents, and it's too common. And speaking out about it makes a difference. I would recommend also speaking to your local, both state and federal legislators, and letting them know about your experience as well. Thank you, Sharon. I'm sorry.
Yeah. Thank you, Richard.
Thank you,
thank you all again so much for joining us. Hope you all have a beautiful Thanksgiving. And please join us for our December webinar on December 20th.
Yes, thanks. Happy Thanksgiving, everyone.